Hello, thanks for coming to today's video. We're going to be discussing ascites. So what is ascites? Ascites is, simply put, is a pathological accumulation of fluid in the peritoneal cavity. And so as you probably already know, peritoneal cavity is in the abdomen, so you'll get a protrusion of the abdomen shown in this figure here. So as you can see, you have this abdomen is kind of coming out in the side here, and and even you have the prominence of the veins, and you can even have some skin lesions all the way around. So that's what ascites looks like. So when you see that, you have ascites. There's a few physical examinations we're going to do, which I'll go to in a little bit, but this is what you want to think of when you think of ascites. So let's talk about pathophysiology. So, how does someone get an abdomen like this and have this accumulation of fluid? The pathophysiology, it's not completely known. However, there are some theories. What they do know, however, is that when people have ascites, they have a state of high sodium and water. Now, why they have this, it's not known completely 100%, but there are some theories. So let's talk about the theories. The first theory is going to be it's called the underfilling theory. So when they talk about underfilling theory, is they're talking about the circulatory system is underfilled. Why is this the case? Well, what you can have is, first you can have portal hypertension. So as you know, the portal system drains from the small intestine and the large intestine into the liver. And so if you have portal hypertension, this increases the amount of pressure that's found in the portal vein, and that can lead to back pressure onto this splanchnic nervous system, splanchnic venous system, and this can lead to accumulation of fluid in the splanchnic veins. And so splanchnic veins is going to be the superior mesenteric vein, inferior mesenteric vein, etc. They all drain into the portal vein. And so when you have accumulation of fluid in the splanchnic veins, that decreases the amount of blood volume that's circulating throughout the body. So you get a decreased circulating blood volume. Well, what happens when you have a decreased circulating blood volume? Your body thinks that you're hemorrhaging, or you have hypotension, or you're dehydrated. So what they'll do immediately is they'll activate the Renin Angiotensin Aldosterone system and the sympathetic nervous system, and to replenish that loss of volume, they'll start having sodium and water retention. So this is one theory. Another theory that develops is called the overflow theory. And in the overflow theory, there actually is no volume depletion, but for some reason or another, the body thinks there is volume depletion, and so then there will just be renal retention of sodium and water. So this is kind of blaming the kidneys on the whole problem. And so when you get this renal retention, you're going to get ascites and even edema. Now, the current theory that's out there is called the arterial vasodilation theory, and this combines both theories together. So it's a really nice theory in that it can explain much more. So how have both these theories come together? Well, again, just like the underfilling theory, it starts with portal hypertension. However, this portal hypertension leads to vasodilation. Why? Well, they've noticed that you have increased mediators, of vasodilatory mediators, such as VIP, substance P, platelet activating factor, prostaglandin, and nitrogen oxidase. Nitric oxide. So what the idea is, somehow portal hypertension is causing vasodilation. And so what happens when you have vasodilation? Well, again, you're going to get decreased circulatory blood volume, and then you're going to get activation of the renin, angiotensin aldosterone, sympathetic nervous system, and sodium and water retention. So this is a nice theory because it's pretty much starting off like an underfilling theory, and it's ending like an overflow theory. So it combines all of them. So long story short, within ascites, what you end up getting is sodium retention, and you also end up getting water retention. And so overall, who wins? Well, water wins, because you end up getting dilutional hyponatremia, and this is probably due to the release of ADH as well. So even though you're retaining both, you still end up becoming hyponatremia rather than hypernatremia. And these are very important prognostic symbols. So someone with severe dilutional hyponatremia is a poor prognostic symbol. So that's something to keep in mind as well. Now let's go into the causes, so the etiology. So the etiology of ascites is divided into two groups, either non-peritoneal or peritoneal. So as you can probably guess, it has to do with the peritoneum or it doesn't, right? So the first one is going to be related to portal hypertension, and this can be first due to some type of liver disease. And the most common one is cirrhosis, which accounts for about 80% of ascites. So definitely want to remember that. Alcoholic hepatitis or even viral hepatitis and hepatic failure is the liver disease causes. On top of that, you can also get some type of hepatic congestion. And so this is some type of backup in the venous system of the liver. This is caused by Budd-Chiari, congestive heart failure, specifically right-sided, constrictive pericarditis, which can backflow pressure up there, tricuspid insufficiency. On top of that, you can have other types of causes such as chylus. You can also have pancreatic, type of fluid going into the peritoneum, bile going to the peritoneum, nephrogenic causes, and even ovarian diseases. So those are some other causes, not necessarily related to portal hypertension, but just overall. And the other type of causes that are non-peritoneal is due to hypoalbuminemia. And so low albumin could be caused by some of those nephrotic syndromes where they're losing proteins to the kidney, protein losing enteropathy, which is found in the GIT, and finally malnutrition. So severe malnutrition can eventually lead to ascites as well. So what are the peritoneal causes? First of all, you have infections, and secondly, malignancy. So it's a little bit more straightforward. So infections is going to be either A, bacterial peritonitis. On top of that, we can also have fungal peritonitis and even TB peritonitis. So that's another cause there. So when you get TB peritonitis, that can also lead to ascites. And finally, HIV can lead to peritonitis as well. Malignancies, there's tons out there, but hepatocellular carcinoma, peritoneal carcinomatosis, and some lymphomas have been known to cause these ascites. So, and those are peritoneal causes. So what are you going to see clinically? Well, first, when we talk about clinically, we'll talk about some of the symptoms that are being found. So first, the symptoms can be related to the actual ascites itself. And so, of course, this is going to be increased abdominal girth. So the abdomen will slowly grow, and this can lead to shortness of breath and early satiety, as well as so the reason why they get early satiety is because, and shortness of breath is because the fluid will actually compress the diaphragm or the stomach and lead to these symptoms. Now, if they have spontaneous bacterial peritonitis, which is SBP, in other words, if they get an infection, this can add on to symptoms of fever, tenderness, and even altered mental status. So that's another thing that we need to look out for. Now, there are also some symptoms related to the underlying cause. This could be due to liver disease. So if someone has liver disease and ascites, they'll also have symptoms related to the fact that the liver is shutting down. And these will be symptoms such as jaundice, gynecomastia, muscle wasting, bleeding, lots of other symptoms. So keep that in mind. And if they got cirrhosis as an underlying cause, then of course you have spider angiomas and the palmar erythema as well again. So there's many other symptoms. So keep that in mind. That helps you kind of with the diagnosis. And if it's due to heart failure, then they might have an elevated JVP. They might have some peripheral edema, or they may even have some type of pulmonary congestion, and that can just kind of point you towards heart failure. And finally, what will you notice on physical examination? Well, you will have flank dullness, and so what flank dullness is when you percuss the sides of the abdomen, it'll be dull. On top of that, you can also have shifting dullness. So what this is when the patient is lying flat on their back, you percuss, it's going to be hyporesonant. However, when they get to their side, it's going to get dull again. And finally, there'll be a fluid wave. So when you tap one side of the belly, it kind of just goes all the way to the opposite end, but not on the surface of the skin, but actually through the inside. So those are your three kind of physical examinations that you want to do. So after you've done the physical examination, there is some investigation that you might want to do. So actually, the way we'll talk about it is how do you diagnose it? So the first thing that will make you suspicious of it is the physical examination, and that's the dullness and the shifting dullness in the fluid wave. After you are suspicious, then you might want to confirm with some imaging. So imaging to confirm. So this can be done either with an ultrasound. An ultrasound can detect anywhere from 5 to 10 milliliters of fluid, and generally this is found in the Morrison pouch, and the Morrison pouch is found, posterior to the liver, so behind the liver. On top of that, you can do a CT scan, and this is what you'll see in a CT scan. So what you have in the CT scan, what I'm outlining here, I'm outlining the liver now, and now it's going over the wall here. So this whole area over here is the actual ascites fluid, and this is the liver. And so you can see the liver is, also looks a little shrunken, so maybe it's cirrhotic. So when you do the CT, you can actually diagnose something in the liver. You might be able to see a tumor or some type of, cirrhosis there. So that's how you'll see the fluid. It's to be a little darker. Okay, so after you've done the imaging to confirm, the next most important procedure would be paracentesis. So paracentesis, when would you want to do paracentesis? Well, the indications are first if someone has new onset ascites. So someone gets new onset, you want to definitely check out the fluid, see what it is. If they have ascites and they suddenly start getting a fever, pain, tenderness, or a high white blood cell count, that's pointing towards spontaneous bacterial peritonitis. You want to look at that. If they get any mental status change, or if they get a sudden drop in blood pressure or drop in renal function and they get a GI bleed. So here in this image here, you can see what a paracentesis is like. So what you'll do is here's the abdomen full of ascites. You take a little needle, and what happens is the needle is then going to drain into a collection. This is going to have a vacuum drain. And so that fluid there, right here, that fluid is then going to go and be tested. So what kind of test would you want to do on that? First, you want to look at the color. And so the color can give you a clue to what it is. So if it's a chylous type of milky color, that's going to be lymphoma. So lymphomas tend to be milky type of color. And this lymphoma could either be due to some type of, not lymphoma, it could be something where the lymphatics is ruptured. And so the lymphatic can rupture either due to a malignancy or cirrhosis. That can lead to lymphatic rupture. And when you check the fluid, you'll see that it has a high fat level, triglyceride level greater than 200. And even the protein is going to be anywhere from 2.5 to 7.0, so it'll be an exudate. On top of that, the color can also be bloody, and generally when it's bloody, there has to be more than 50,000 red blood cells per millimeter cubed. And if it's pink, then it's going to be right around 10,000. So when can this occur? Well, it can occur with a traumatic paracentesis. So this is actually an error in the way with the way you're pulling out the fluid. So this must be ruled out because this is just an erroneous finding. Also, cirrhosis can cause a bloody tap, and hepatocellular carcinoma can cause a bloody tap. And let me now when I said chylous, I meant milky, not cloudy. Now cloudy and turbid, that is another sign. That generally tells you that there's an infection such as SPP, and that's about 98% accuracy there. So when you see cloudy and turbid, you can just pretty much right away know that it's bacterial cause there. Okay, what if it's brown? Well, brown is due to jaundice, and perhaps even maybe a ruptured gallbladder, or it might also be due to a perforated duodenal ulcer. So that's when you get brown. Now, these are relatively uncommon. What is the most common? That is when it's clear. And so when it's clear, that probably means it's due to some cirrhosis. And uncomplicated cirrhosis, so there's nothing really going on more than that, and that's usually what you'll get. So we do want to run other tests. The SAAG test, also known as the serum ascites albumin gradient. This is a very important test. What you do is you take the serum albumin and you subtract it from the acidic albumin, and that is going to be your SAAG. Now, if it's greater or equal to 1.1, then you have portal hypertension. And so you want to look for causes of portal hypertension. And if it's less than 1.1, then it's non-portal hypertension. And this is about 97% accurate for portal hypertension, so really strong test. So you want to do that, and you also want to do a cell count right away. And you might want to do a cell count before, because if you have a high white blood cell count or a high neutrophil, then this signifies SBP, and you want to make sure you treat it right away. Now, if it's a bloody tap and you're looking at the cell count, you do need to do a correction. And so for every 750 RBC, you want to remove one white blood cell, and for every 250 RBC, you want to remove one neutrophil, because obviously if you have RBCs in there, then you're actually getting these cells from the blood rather than actual in the peritoneum due to inflammatory reasons. So you want to make that correction. So these two are the most important tests that you always want to do. However, there are some other tests that you want to do, and you want to do it depending on maybe the associated symptoms or what's going on in the picture there. So culture, you want to try if there's some type of infection that is suspected. You might even want to do a glucose, and glucose tends to be low in patients with some type of malignancy, or if there is some type of bowel perforation. So that's when you want to check out glucose. LDH is another good test. If it's lower than 1.0, then it's cirrhosis. If it gets closer to 1.0, it's around 1.0, that's going to be SBP. And if it's greater than 1.0, then you're looking at some type of infection, perforation, or some type of tumor. So that's a nice test there. Gram stain, kind of like culture when you're suspecting an infection. Amylase, if you're suspecting some type of pancreatitis. Biopsy, TB, that's good for TB, and also ADA, adenosine deaminase is good for TB as well, and total protein as well. That helps you differentiate whether you're dealing with an exudate or a transudate. Now, this isn't used as much anymore with SAAG. That tends to be a little bit better. However, it's still useful, because if someone has high SAAG and high protein, that's going to probably suggest some type of hepatic congestion. However, if they have low SAAG and high protein, then that's probably more suggestive that the individual has a malignancy. And real quick, what classifies a transudate? When it's less than 25 grams per deciliter, and then obviously then an exudate is when the protein count is greater than 2.5 grams per deciliter. So that is the investigations you'd want to do. Now we can just move on to the treatment. So your initial treatment would be trying to alleviate some of the symptoms that they may have. So initial treatment here. And you can alleviate those symptoms by doing a quick therapeutic paracentesis. So therapeutic paracentesis. Now, depending on how bad it is, you might want to do a small volume or large volume. So small volume is when it's less than 5 liters. And you might want to do some saline, replacement for the volume that's lost as a plasma expander. Or you could do large volume, which is greater than 5 liters. And once you get to this level, you probably want to replace them with 5 grams of albumin for every liter above 5 liters. So, and this will help, kind of prevent you from getting some of the electrolyte abnormalities and those things that may happen. So keep that in mind. Now, what about long-term type of treatment? You want them to cut out alcohol, even if they don't have cirrhosis, because that has been known to help. You want them to decrease the sodium and water intake to prevent that as well. And then you want to give them some diuretics, so maybe furosemide and maybe a spironolactone as a potassium sparing. On top of that, you want to manage any underlying cause that they may have, so you want to treat that. Now, surgery, if it's kind of refractory to treatment, there are some surgeries you can do. One is the TIPS procedure, also known as the transjugular intrahepatic portosystemic shunt. So what is done in this? Let me get TIPS. Okay, let me get a diagram here. 1 sec. Okay, there you go. So in this diagram, we have the liver here. So this is we have the jugular vein coming up here, and it's going down to the hepatic vein, and this is the portal vein. So what you do is you take a wire and you bring it all the way down here. So you bring the wire all the way down from the hepatic vein into the portal system. And then once the wire goes in there, you're going to go ahead and dilate it. So you can see how they dilated it there. And then you put in a meshwork around it. And now it's going to avoid the vessels in the liver. It's going to go straight from the portal system, jumps into the hepatic vein system, and it skips the liver altogether. And so this has been helpful for a lot of patients. However, when you skip the liver, you don't detoxify a lot of the things that need to be detoxified, and so it can lead to some symptoms later on, but overall this is pretty well tolerated. And finally, you can also do a liver transplant, so that's an option as well, and of course that would be kind of more of a definitive type of treatment. So that is my Ascites presentation for today. Hope you guys enjoyed, learned a lot. I will see you in my future videos. Bye.